Am I audible to all of you? Okay, Cecil, good morning. कतिजना भएछ त automatically add हुँदै जान्छ है. Okay, so by now you are 46 participants, so keep on getting connected, and meanwhile you connect to the class. We begin the class. Okay, so today we are going to talk something about conductive hearing loss and also something about otosclerosis. Okay, so let us go to the conductive hearing loss. Okay, by now you should be knowing that there are three types of conductive hearing loss. Okay, now there are three types of hearing loss. One is conductive hearing loss, next is sensory neural hearing loss, and another one is mixed hearing loss. Okay, so this is the classification. So hearing loss can be divided into organic and non-organic type. So when we say it organic, it means that there is some disorder or there is some pathology. And when it is non-organic, it means that it may be psychogenic or it may be malingering. Okay, Pinky, good morning. Okay, let us go back. Let us go to here. Okay, so whenever there is a pathology or disorder, then it is organic, and whenever there is no disorder or no disease, then it is non-organic, like psychogenic or malingering. So you should be knowing malingering, right? Do you know this word? So it means that faking. Some people they fake that okay they can't hear. Some people they fake that they can't speak. Okay. So in my practice, I've seen many patients who are malingerers, who fake that they can't hear. And one of the reasons that I found out that they're doing this is because recently our government has been giving them some amount of money every month, in form of allowances, handicap allowances. So sometimes, like they come to the OPD and they say that the Putin audiograms, they might be normal in case of malingering, but then there are different other tests that can differentiate between malingerer or non-malingerer. Okay, so you should be careful about these things. And whenever you go to the PHC or in the periphery or even in the central hospital after you have completed your MBBS, so people may come to you and ask you to make a certificate, a handicap certificate. And you should remember that whenever you sign a document, it is a legal document. So before you sign anything, so examine the patient and be very careful and very vigilant. Okay. So now about the organic causes. So organic can be divided into two types, the conductive and sensory neural type. Then we have another type which is called the mixed type. So in the mixed type there is conductive hearing loss and the sensory neural hearing loss. And then again the sensory neural hearing loss can be sensory type when it is involved only to the cochlea, and the another is neural type when the nerves are involved, the earth nerve and the central auditory pathway. Okay, let us go to the next slide. So how do you define a conductive hearing loss? Any disease process which interferes with the conduction of the sound to reach cochlea causes conductive hearing loss. So have you done with physiology of hearing? So if you have done that, then you should be knowing all the parts of the ear, the external ear, the middle ear, and the inner ear. They have different roles in the conduction of the sound. Okay, and whenever this mechanism is disrupted up to the level of the middle ear, then it will cause conductive hearing loss. So in case of conductive hearing loss, the lesion may be present in the external ear, which comprises of the pin. Okay, so we are not concerned about the pinna. So external auditory canal in this case. So even if there is any lesion in the pinna, so it is not going to cause any problem with the hearing. Similarly, tympanic membrane, verimus, and the ossicles. Okay, so if there are lesions in any of these parts, it will cause conductive hearing loss. Okay, so now let us go to the next slide. Now, this slide is important because you need to know what are the causes of conductive hearing loss. Okay, causes of conductive hearing loss is quite different from causes of sensorineural hearing loss. So the causes can be divided into congenital and acquired. So the congenital causes can be metal atresia. Okay, so we have already talked about this. It means that the ear canal is narrow, or it is just occluded. Similarly, the fixation of the stapes foot plate. Okay, stapes, it has different parts, and foot plate is one of the part that is attached to the vestibulum, which is also called the stapedial vestibular joint. Okay, and if it is fixed, then there won't be any proper movement, and hence there will be conductive loss. Similarly, the fixation of the malleus head. Okay, the ossicles in the middle ear, they are normally mobile. And if there is any fixation of the bones, then it is going to cause conductive hearing loss. Similarly, the ossicular discontinuity and congenital cholesteatoma. Okay, so more than the congenital causes, the acquired causes are more important for us. Okay, so you do not have to copy this. This slide has been lifted from Tingra, and you can find it there. Okay, this is a very good chart. And whenever you find some charts or some diagrams in your textbook, so make sure that you read it for multiple times. It is in a chart, it is in a box because it is important. Okay. So the acquired causes can occur either in the external ear or in the middle ear. Okay. This slide, this is the external ear, and the tympanic membrane ossicles, they are the middle ear. Okay. So any obstruction in the ear canal, it can be caused either by wax, or it is very common. Everybody of us gets wax in the ear canals. Okay. And in some cases, it gets impacted, and hence it can result in hearing loss. Similarly, foreign body, furuncle, acute inflammatory swelling. So what you should know is that all of these conditions like wax, furuncle, or all of these things, they will cause the occlusion of the ear canal. And whenever there is occlusion of the ear canal, it will cause obstruction to the conduction of the sounds, and hence there will be conductive hearing loss. Okay. Okay, so this is clear. So now we come to the middle ear. So this is more important. Okay, because there are so many conditions that can occur in middle ear. So one of the commonest causes is perforation of the tympanic membrane, traumatic or infective. Okay, so perforated tympanic membrane is a very common condition, and it is mostly infective. Like the patient will have acute otitis media, and the pus will, okay, don't draw on the slide. Okay, so, and the pus will it will increase, it will become more tense, and then it will just rupture and make a perforation in the tympanic membrane. And and when the pus is when the pus is getting built up behind the tympanic membrane, it needs a place so that it can come out. So because tympanic membrane is a very thin organ, so it will just perforate the tympanic membrane, and the pus will come out, and hence there will be a tympanic membrane perforation. Similarly, traumatic tympanic membrane perforation is very common. Many of us, we have habits of picking the ear, either with the earbud or like the keys or many of the pointed things. Okay, and by mistake, like, we tend to go deeper inside and we perforate the tympanic membrane. Similarly, violence or physical assault, it is very common in this part of the world. And when somebody is hit with a slap of hand on the ear, it will cause the pressure, okay, the gushing of air, and that air pressure will just perforate the tympanic membrane. And this perforation of the tympanic membrane is a very common cause or major cause for conductive hearing loss. Similarly, fluid in the middle ear. Example in acute otitis media, serous otitis media, or hemotympanum. So, okay, acute otitis media. So, okay, infective causes and otitis media with infusion and hemotympanum. Whenever there is a trauma, so there is a collection of blood. So, hemotympanum means blood in the middle ear. So, normally there should be air in the middle ear, and because fluid, pus, or blood, they are more dense. So that will cause some loss in the conduction of the sound waves. Okay, and it's obvious if there is a mass in the middle ear, either benign, malignant, so it will cause conductive hearing loss. And again, we talked about it earlier. Okay, disruption of the ossicles. Okay, it can be either traumatic, especially due to the ossicular chain, and the ossicles can be disrupted even in chronic suppurative otitis media and cholestoma, because uh, these diseases will cause erosion of the ossicular bones and reabsorption of the ossicular bones, and after a long time, the person like there will be the disruption of the ossicles and the hearing will decrease. So you should be knowing that whenever a person comes to us with a history of chronic otitis media, we tell him to get operated earlier. And if he delays the operation, what happens is that because of the disease process, the bones will keep on getting reabsorbed, and after a long time, the hearing will just worsen and only worsen. And similarly, okay, this condition that we are going to talk about today, okay, fixation of the ossicles, okay, that occurs in the otosclerosis, tympanosclerosis, and adhesive otitis media. So we are going to talk more about the otosclerosis in the later slides and something about the tympanosclerosis. So in some tympanic membranes, what you see is there are white patches, okay? So these are the calcified patches. So normally this shouldn't be present there, but whenever the calcification is present there, it means it will decrease the mobility of the tympanic membrane. It will fix the tympanic membrane. So, and whenever the tympanic membrane can't move as it is supposed to move, then it will deter the conduction of the sound, and hence there will be conductive hearing loss. And more about otosclerosis later on in the coming slides. And similarly, Eustachian tube blockage. Example, retracted tympanic membrane, serous otitis media. So Eustachian tube is a very important part in any ear disease. Okay, most of the ear diseases, especially the middle ear diseases, they begin because of the defect in the Eustachian tube. So, the role of the Eustachian tube is to maintain the pressure between the middle ear and the external environment. But if there is tubal occlusion or like some dysfunction of the Eustachian tube, then the middle ear, the air inside the middle ear will get absorbed in next few days, and after that, and then there will be negative middle ear pressure, and because of that, the tympanic membrane will be pulled inside, and when the tympanic membrane is distracted, its mobility is decreased, and hence there will be conductive hearing loss. Okay, like you'll get many patients who come to you and they'll say that, okay, doctor, like my ears, they are very heavy, like I do not have any problem with such, but in like I had rhinitis, right? The rubella थियो कान एकदम भारी भारी भइरहेछ अरु के भएको छैन. So you should think about Eustachian tube blockage because of any pathology in the nose will cause Eustachian tube blockage, and whenever there is Eustachian tube blockage, then you may get the retraction of the tympanic membrane, okay, and hence conductive hearing loss. Now this is an important slide, okay, and time and again you'll be asked about this in your Viva exams. Okay, ESL is not some sort of hearing loss, it is just average hearing loss, okay? So average hearing loss in various lesions of conductive apparatus, okay? So till now we talked about, okay, the conductive hearing loss can occur anywhere in the ear canal or in the tympanic membrane or in the ossicular chain, right? So when any one of that organ is involved, so what is the degree of hearing loss? So you should know that. Or suppose you see a pure tone audiogram, okay? Audiogram. So audiogram is a test. It is a test of hearing which will tell you about the degree of hearing loss and the type of hearing loss, okay? And suppose when you find an audiogram and you see that it is, okay, and when you see the degree of hearing loss, you should suspect some sort of pathology, right? So whenever there is complete obstruction ear canal, the hearing loss can be in the range of 30 decibel, okay? And whenever there is perforation of tympanic membrane, okay? So complete obstruction ear canal, it can be either by phonoglosis or most commonly by the wax. And whenever there is portion of tympanic membrane, the degree of hearing loss can be in any range from 10 to 40 decibel. Okay, and this loss of hearing depends upon the size of perforation. Suppose when there is very small portion, less than 10% of the tympanic membrane, then the hearing loss is less. Sometimes there can be subtotal, or sometimes there can be total perforation. In such cases, there will be the hearing loss will be more. Okay, ossicular interruption with intact drum. Okay, what like there is malleus, incus, and stapes, but it is interrupted, and the tympanic membrane is normal. So in such cases, and you know that the main function of the ossicles is to transmit the sound. Okay, so in such cases, the hearing loss can be as high as 54 decibel. Okay, and look here, ossicular interruption with perforation. Okay, so these 2 points is important. So you may think that perforation of tympanic membrane and ossicular interruption, they should act synergistically. By that, what I mean is that, so you may be thinking that if there's ossicular interruption, and so then there is 54 decibel of hearing loss. But if perforation of tympanic membrane is aided, so the hearing loss should increase, you know, but it doesn't happen like that. So if there is ossicular interruption, but there is perforation, then the hearing loss won't be as high as with an intact drum. So this is an important point, and it is because of the perforation. Okay, just give me a second. Oh, hello. नमस्ते ल म अहिले क्लासमा छु म कल गर्छु है अहिले एकछिनमा 10 बजे ल है है अहिले त म क्लासमा छु है म कल गर्छु okay. And so okay, whenever there is ossicular interruption and perforation, so it means that the sound waves can still transmit to the oval window in some way. Okay, but it is not normal. There is hearing loss, definitely some hearing loss, but it is not as much as when there is intact drum. Okay, and in case of malleus fixation, it can be in the range of 10 to 25 decibel, and if there is a closer oval window, it can be up to 60 decibel. Okay, so you need to remember all these points. Sometimes in the Viva exams, you can be asked, okay, how much may be the hearing loss if there is malleus fixation, or if there is a perforation of the tympanic membrane. Okay, different books may have different values, but this is, you need to remember that this is the average hearing loss. Okay, so it should be, so whatever you answer, it should be in the close proximity of this data. Okay, so these are usually asked in your Viva exams. Now in the last slide, okay, this is what you get, this data is what you get from an audiogram. Okay, so this is an audiogram, which we commonly also known as pure tone audiometry. Okay, it has 2 axes. Okay, okay, this is what it is. Okay, your x-axis and y-axis. All right, and these are the frequency in hertz, 125 to 8,000 hertz, and this is the hearing loss in decibel. Okay, now we'll look at this part. Okay, this is also important. So you need to know that an audiologist always uses pens of 3 colors. Okay, one color for the right ear, they always use the red color, and for the left ear, they always use the blue color, and the black is to write the diagnosis and all other details. Okay, so whenever blue is used, always you know that it is the left ear, and when it is red, it is the right ear. Okay, so that to differentiates. And then there are different markings. Okay, for air conduction, bone conduction, and no response. Okay, so look here. Now these are the arrowheads. Okay, so this is the bone conduction. So the look here, it is the 0 hearing loss here, 10 here. So the bone conduction, okay, 25 is the normal range. Okay, so anything above 25 is regarded as hearing loss, and up to 25 can be regarded as normal hearing. Okay, it depends. Like the WHO also has a different classification. Other groups, they have different classification. Some say that only up to 15 is normal hearing, but up to 25 is, it can be considered as normal hearing. Okay, so the bone conduction is in the normal range. But look here, this is the air conduction. Okay, this round circle. Okay, so when 250 hertz of pure tone was applied. The person heard it only after 40 decibel of sound was sent to his ear. So the 40 is marked here. And when 500 hertz was given, so it took the audiologist to give him 50 decibel of sound. Then only the patient could hear. Okay, and this way, this is bulleted on this graph. Okay, and in the end, the average is taken, and that is mentioned as the hearing loss. Okay, so the figure is so that the audiogram of the right ear showing conductive hearing loss with air bone gap. Okay, this is AB means air bone. Okay, so this is the bone conduction, air conduction, and you see here there is air bone gap. So it must be more than 10 to 15 decibels, so as to term it is a conductive hearing loss. And this is the legend. Okay, the symbols that are used in the audiogram charting. Okay, so we are going to talk more about these audiograms in the later classes, or we'll just mix it up with your other diseases. Okay, so in your exams, you may be given an audiogram. In your Viva exam, practical exam, you'll be given an audiogram, so that, and you'll be asked to tell that, okay, suppose you're given, or you also have OSCEs, okay, you'll be given an audiogram like this, and you'll be asked, okay, what sort of hearing loss does this audiogram show? Okay, then your answer should be conductive hearing loss. And then there can be other questions that will follow this question number 1. Okay, the next question can be, in what diseases can you get conductive hearing loss? Mention any 2 diseases or 4 diseases. Okay, so this is also important for you. Now management. Okay, so by now you should have known that, okay, in what cases you get conductive hearing loss and when you call it conductive hearing loss. So how do you manage it? Okay, again, this slide, you don't have to write it down or take any screenshot. Okay, this is again lifted from your DINGRA. Okay, most cases of conductive hearing loss can be managed by medical or surgical means. Treatment of these conditions is discussed in respective sections. Briefly, it consists of, okay, so in your subsequent classes, we'll talk about, meningotomy, tympanoplasty, so many things. So generally, conductive hearing loss can be treated by removal of the canal obstruction. Like if there is impacted wax, okay, take out the wax, the canal will be patent and the patient can hear. Okay, or if there is a foreign body, so remove the foreign body and the canal will become patent and the patient can hear. Similarly, osteoma or exostosis, they are the bony growths, and if that is obstructing the sound transmission of the sound, then just you remove it, okay, by surgery, and the patient can hear. Okay, keratotic mass, okay, it mimics impacted wax, but it is a little different, and this should again be taken out so that the tympanic membrane can get the sound. Similarly, if there are benign and malignant tumors in the ear canal, this should be removed, and if there is meatal atresia, a meatus should be made. Okay. Similarly, the removal of fluid. Okay, there can be serous otitis media or otitis media with effusion, or even acute otitis media, suppurative otitis media. So, if it is inflammatory cause, then the antibiotics will help to treat the disease. But in some cases, like otitis media with effusion, the medical therapy may not treat the disease. In such cases, you need to make a perforation or make a hole in the tympanic membrane, okay, and drain the fluid. Okay, so when the fluid is drained, there will be air in the middle ear, and when there is no fluid but air in the middle ear, so the transmission of the sound becomes better. So I'm not sure if you have been taught about this, but if you have not been taught about this, then we'll take another class. You should know what is meningotomy. Okay, meningotomy is making a hole in the tympanic membrane. But so in case of otitis media with effusion, we do it to drain the fluid. But because after meningotomy, there are the flaps of the tympanic membrane, so that may close. So in such cases, we put grommet after doing meningotomy. So grommet is nothing but just a small tube-like structure. It is very small, and after making the hole, this tube is kept in the tympanic membrane so that the fluid is draining to the external ear. or in a way, so it causes the ventilation of the middle ear. Okay, so that is grommet. Now removal of mass from the middle ear. Okay, tympanotomy and removal of the small middle ear tumors or cholestoma behind the tympanic membrane. Okay, when we come to find out that there is a mass in the tympanic in the middle ear, it should be removed. We just elevate the flaps of the tympanic membrane and then we take out the mass and then we reposition it. And we are going to talk about it today. Stapedectomy. Okay, it is a surgical procedure. So whenever there is otosclerosis, and whenever so in otosclerosis there is fixation of the stapes foot plate. So stapedectomy is done so is to release the fixation, and so that there is the movement of the stapes foot plate and hence the conduction of the sound. And now tympanoplasty. So whenever there is the perforation of tympanic membrane, we need to patch the tympanic membrane. Okay. So that surgery is called tympanoplasty. Okay. So in tympanoplasty, the tympanic membrane is repaired and also the diseases of the middle ear, they are cleared. But when only the tympanic membrane is patched up, it is called meninoplasty. Okay. And similarly, ossicoplasty can also be done. Okay. So in ossicoplasty, ossicular chain is repaired. Okay. And you know that if there is disruption in the ossicular chain, there won't be any conduction of sound or decreased conduction of sound. So plasty means repair. So if the tympanic membrane is perforated, repair the tympanic membrane. Ossicles is damaged, so repair the ossicles, ossicoplasty. And if both of them are damaged, then you repair both of them. And in many cases, when surgery is not possible, in such cases, you ask the patient to use hearing aid. In cases like when the patient has so many comorbid diseases, when surgery is not indicated, and similarly, there are many patients who are afraid of surgery. So in such patient, hearing aid is recommended. And in patients who are quite old and who are nearing the end of their life, so in such cases also hearing aid can be a very good option. Okay. So many patients they refuse. So in such cases, use hearing aid. It is just like a earphone. Okay. And maybe later we may take a class for you on hearing aid. Now this was something basic about the conductive hearing loss. So now we are going to talk about otosclerosis, in which there is fixation of the foot plate of the stapes, and that will cause conductive hearing loss. Okay. So it is a hereditary disease of bony labyrinth showing replacement of lamellar control bone by irregular layered new bone. New bone is spongy plus more vascular in active otospongeosis, but thicker and more cellular in inactive otosclerosis. Okay. Sometimes otospongeosis can be used interchangeably with otosclerosis. Okay. Okay. So what is the epidemiology of otosclerosis? It is like etiology is not. It is not known. It may be viral. Okay. So anything that we do not know may be viral. Okay, it is an autosomal dominant disease, variable penetrance. Okay, race. It is more common in white races and also in Indians. So female to male preponderance is 2:1. More female are affected than male. And it is common in, okay, the meeting will end in 10 minutes. So I hope that we can finish it in 10 minutes. But if it won't be possible for it to finish in 10 minutes, then we'll add some more minutes, okay? So yes, it is more common in the age group of 20 to 40 years, the youngsters. So it is very uncommon before 10 years of age, and also again very uncommon after 40 years of age. And there can be some hormone influence to like, otosclerosis in more in pregnancy, in menopause, and stress, either by trauma or surgery. Now there is this one terminology that you need to know, Van der Hoef syndrome. Okay, so here otosclerosis. Okay, and as a result, deafness plus osteogenesis imperfecta, which means recurrent fractures, and blue sclera. So it is a triad of these three things: deafness by otosclerosis, recurrent fractures by osteogenesis imperfecta, and blue sclera. So this will cause Van der Hoef syndrome. So you may be asking you, final exams about this disease. Okay, so mention what forms the triad known as Van der Waals syndrome. Now, types of otosclerosis. Okay, so it is not very important for you, but still you need to know. Okay, it can be stapedial, it can be cochlear. Okay, otosclerosis focuses in over the round window and promontory, and it can be stapedial plus cochlear, so that will give the mixed type, and then there can be malignant type. Okay, rapidly progressing cochlear lesion with severe sensorineural difference. Okay, so we are more concerned about the stapedial type. Okay, 10 मिनट भनेर भन्यो है, त हेर म थप्नु परेन, अहिले पछि थपौँला है, 8 मिनट देखाएको छ है ल. So what are the different types of stapedial otosclerosis? Okay, stapes footprint, okay, anterior crura, posterior crura. Okay, so interior focus, it is the commonest type. It occurs 2 mm anterior to oval window. So you know that the stapes footplate is attached to the oval window, and at oval window it will form stapedial vestibular joint. Okay, there is one message here. Okay, ल क्लासरुम सियरले यस्तो कुरा बुझेपछि कम चालो सरहरूले देन ल होइन एउटाले मेसेज पठाएको छ इच्छाले. ओके, ठीक छ इच्छा. ओके, you talk with your CR, and for your CR you pass this message to the coordinator of the 4th year, which is our ENT teacher, Dr. Tilak, and they will talk about these things. And like I'm not authorized to comment on this, but well, I'll tell this thing to Tilak sir. तपाईँको नि मेसेज आछ देखेछ ल. I 2 mm into the oval window, posterior focus. Okay, here you can see the posterior focus 2 mm behind the oval window. So this part lies in close proximity, okay, or this attached to the oval window. And similarly, the circumference, it involves the footplate margin only. Fake हो, but ठिकै छ, फेकको लागि त किन स्टकको फैलिराख्ने है. ओके, फेकको रहेछ त कस्तो कमली हो. And then there is another one is the biscuit type. Okay, footplate is involved, margin is free. Okay, look here, the footplate is involved, the margin free. And the obliterative type. Okay, it obliterates the oval window completely, like in this case. Okay, so these are the 5 different types of the stapedial otosclerosis. Right? Anterior cross, posterior cross, and the circumferential type. Okay, ठीक छ समीर. Okay, we'll talk about this with the management, and यसलाई चाहिँ कसरी अब हामीले चाहिँ गर्न सक्छौँ है. ल ठिकै छ है, आफ्नो काम गर्दै जाउँ है. Okay. Now, what are the symptoms of otosclerosis? Okay, number 1 symptom is the deafness. Okay, it is bilateral and it is slowly progressive. Okay, this is very important, and like when you begin to practice as medical officers or as ENT surgeons, then the patient will say that, okay, no, it was not abrupt. It began to increase in severity slowly and slowly, and it occurs in both ears. Okay, so the difference can be conductive. It is stapedial otosclerosis, and it can be sensorineural if the cochlear otosclerosis is present, and it can also be mixed if there is stapedial plus cochlear otosclerosis. Soft modulated monotonous voice, tinnitus, and vertigo, which is seen in cochlear lesions. Okay, and paracusis Willisi. Patient has better hearing in noisy surroundings. So it is because like the patient, like suppose we have otosclerosis, and you are in the noisy surrounding, and you are talking to somebody with normal hearing. So because of the noise, the patient the person who is talking to you will increase the pitch of his voice or the degree of his voice, and because of that, the patient with otosclerosis show that, okay, I can hear him better in noise. I can hear better in noisy environment. Now, okay, the tympanic membrane is normal in most cases of the otosclerosis. There is a pinkish color over the promontory. Okay, and it is seen only in 2 to 10% of the cases. Okay, it is also known as Schwartz sign and Okay, also flamingo pink flaws. Okay, this sword signs and flamingo pink flaws. Okay, this can sometimes be asked in your OSCE examinations. Okay, so by normal tympanic membrane, what I mean to say is that it is not perforated. Okay, it is intact. Now, pure tone audiometry. Okay, this is very important in case of otosclerosis, and sometimes it is one of the major diagnostic criteria to diagnose otosclerosis. Okay, this is the normal. This is the bone conduction. Okay, and this is the air conduction. Okay, so you can see that there is low frequency conductive deafness here. Okay, so the hearing loss, the air conduction is lesser in lower frequencies, but with higher frequency it has improved. But look here, at 2000 Hz, there is deepening of the bony conduction. So this deepening of the bony conduction is called as Carhart's noise. Okay. Again, this is a very important MCQ question. What is Carhart noise? Where do you find Carhart's noise? Okay. If you find a Carhart noise, what disease do you suspect? Okay. So the deepening at the 2000 Hz in the pure tone audiogram is called Carhart noise, and it is common in otosclerosis. Now, why there is deepening in 2000 Hz? Okay, so there are some proposed theories. Okay, stapes fixation disrupts normal ossicular resonance at 2000 Hz. Normal compression mode of bone conduction disturbed because of relative perilimb immobility and mechanical artifact. Okay, Carhart's noise reverses with stape surgery. Okay, what you need to know is that it occurs at 2000 Hz. Okay, you do not need to know these proposed theories, but because this is something interesting, okay, it is good to know. Okay, Suman, like we'll have another class on hearing. Okay, so we only talked about the conductive hearing loss, but later on we'll have a class on pure tone audiogram and how to read the pure tone audiogram. In fact, these things are done in your clinical classes. I know how to examine the tympanic membrane, how to read the tympanogram, or how to read the audiogram. Okay, so these are usually taught in your clinical classes, but like because of the corona pandemic, clinical classes are not possible. So we'll find out a way. Okay, it has already been done, but you should already know this. Right? Now, okay. Now let's go to the next slide. I'll find this up in next one. Okay, now we'll just skip over these two slides. Okay, CT scan of temporal bone. It can be done in Otosclerosis, but it's not always required. Okay, so this was Stapedial Otosclerosis. Okay, you do not need to know these things, but just and here the cochlear otosclerosis, double ring sign or the halo effect. Okay, so what are the differential diagnosis of otosclerosis? Okay, okay, the differential diagnosis are otitis media with effusion. But then how do you rule out otosclerosis from otitis media with effusion? In otitis media with effusion, you get type P tympanogram that you don't get in mutilation. Okay, I'm sorry. So by differential, okay, so you need to know the differential diagnosis of otosclerosis, and you need to know how you differentiate those conditions from otosclerosis. So conductive hearing loss can be present in otitis media with effusion, but you differentiate otosclerosis by finding type B tympanogram. Similarly, adhesive otitis media. Okay, in adhesive otitis media, the tympanic membrane is, it is glued to the middle ear. Okay, so you can just differentiate it by the absence of mobility of the tympanic membrane. Okay, tympanosclerosis, it is very easy to diagnose this condition. In tympanosclerosis, you find white calcified patches on the tympanic membrane. Maybe later on I can show you a diagram or a picture of that. Okay, and ossicular discontinuity. So in ossicular discontinuity, you get AD type of tympanogram, okay, and congenital ossicular chain fixation. So you can find it by tympanotomy, and Malleus head fixation again by tympanotomy. So this is how you rule out the different differential diagnosis of otosclerosis, and you can just be sure that it is only otosclerosis. Okay, so the treatment part of otosclerosis. Okay, surgery is commonly done and it has very good results. So what are the inclusion criteria for surgery? The pure tone average should be between 30 to 60 decibel. Airborne gap should be more than 15 decibel. Okay, so only when there is airborne gap, we'll say that it is conductive loss. If the airborne gap is very less, and even after surgery, there won't be any improvement in the hearing. So it won't be of any use to do surgery. Similarly, speech discrimination score of more than 60% and absence of sensorineural hearing, sensorineural deafness. Okay. Okay. In the cochlear type, there is sensorineural deafness. Okay. But if you do surgery, stapedectomy, sensorineural deafness, so you are not going to treat the hearing loss. The patient usually comes to you to get his hearing loss treated. Okay. So the surgery will only treat the conductive hearing loss. Now, what are the contraindications for surgery? Okay, if it is the only hearing ear, so because there are so many complications that are associated with this surgery, stapedectomy, so you should be very careful. Okay, it is not exactly a contraindication, but if the patient has, if otosclerosis has occurred only in the only hearing ear, so it should be done by expert hand or only by the senior or very expert ENT surgeons. And similarly, in otitis media, so it's no use doing this surgery. In the extreme surface, okay, in pregnancy, in otitis externa, and in Meniere's disease, okay. Similarly, in divers, in high construction workers, in frequent travelers, and in people working in noisy surroundings. After stapedectomy, the patient may get vertigo, and those patients working as divers or high construction worker, and if they get vertigo, then their life can be at danger. Now, complications of surgery. Okay, so I'll just read it out, and you just try to get a basic idea. So those complications that are can be divided as intraoperative and postoperative. Okay, the intraoperative can be floating footplate, submerged footplate, dislocated mucus, perforated tympanic membrane, damage to the facial nerve or coda tympani, persistent stapedial artery, and perilimb flooding. Postoperative complications. Okay, otitis media, overwindow granulation, perilimb fistula, sensorineural hearing loss, persistent airborne gap, vestibular dysfunction, delayed facial palsy in laser surgery. Okay. Now, surgery was the name of the surgery that is done is stapedectomy or stapetotomy. Okay. So apart from surgical intervention, there is some medical therapy too that can be done in otosclerosis. Okay, the sodium chloride can be tried in patients with otosclerosis. Okay, so it is especially given in cochlear otosclerosis and active focus of otosclerosis, especially whenever there is Swar sign present. Okay, it acts by decreasing the bone resorption and it increases bone formation, and it also prevents enzymatic damage to cochlea. Okay, it is given as 20 mg orally thrice a day for 3 to 6 months. Okay. So we can find some patients who are unwilling for surgery. So in some cases like this, we can try this. But look here, the treatment is for 3 to 6 months, and the results they are not. The results are not very clear. So in my practice, like I have never, done this therapy, the sodium chloride therapy. So in patients who are unwilling to go for surgery, the best option is hearing aid. Okay, for patients who are unfit for surgery and for those who refuse surgery. So basically, there are two types of management for otosclerosis. One is surgery, which is very commonly done and which also has very good results, but the complications are also very high. Okay, but in patients like who refuse surgery, in such cases, use of hearing aid can also give very good results. Okay. Okay, so this is all for today. Okay, just give me a minute. Okay, class. So that was something about conductive hearing loss and something about otosclerosis. Okay, so I joined otosclerosis with conductive hearing loss because otosclerosis is a major cause for conductive hearing loss. Okay, so I hope you are clear up to here, and like if you have any questions or something like this, then we can always discuss it, and we'll try to see if some other sorts of clinical classes can be arranged for you, so that like you get to see some patients and also read audiograms and other things that you can get to see in the ENT OPD. Okay, so should I end the meeting?